Hi, everybody. Welcome to another edition of Cosmetic Corner. Tonight, I am very excited to welcome Dr. Jean Carruthers. Many of you are familiar with her. She's done so much in the field of research, as well as clinical training and injectables. And really, the focus today is to work on the filler-induced blindness. So let's get Dr. Carruthers in here. Hi there.
Hi, how are you?
I'm good.
Great.
Good to have you. Welcome.
Thanks so much for asking me.
Oh, it's a huge honor. We're very excited. And on behalf of the Aesthetic Surgery Journal and Cosmetic Corner, it's exciting to bring you on tonight to talk about your recent paper that won an award, actually, Best Domestic Paper in ASJ. Congratulations.
Well, thank you so much. I just want to share the credit with all my co-authors. It was a big job and a great team.
That's awesome. Well, it really helps us talk about a difficult topic. And you and I visited about this a little bit, this concept of vision compromised by filler injection, a topic that we still don't know a lot about, but we're trying to learn more. And so your paper, which was titled Update on Avoiding and Treating Blindness from Filler Injection, a review of the world literature, had some really alarming stats. And it wasn't your first paper, actually. The first paper you did was a review of 114 years of literature. You demonstrated 98 cases. And then just in this 3-year span of the second paper, there were 48 cases. So clearly the incidence is increasing, which means we have to understand a little bit better. And before we jump into the questions, I just want to share with the audience a couple of the alarming stats that really grabbed my attention when I read the paper. First and foremost, right, the initial one was mainly from fat injection, right? The first paper was mainly fat injection, whereas now 81% of the cases in the last 3 years that you covered were hyaluronic acid.
Yes.
And so we do see that the HA certainly is increasing in injections for sure. The other thing we noticed is that there was a 2% recovery in that initial 114-year span that you looked at. And then between partial and complete, almost a 38% recovery. The issue being not everyone did a pre-screening exam, right? So how to really define partial versus complete vision loss.
Right.
And the other key thing I thought was interesting was obviously the nose. So the nose kind of took over the glabella as this new area where it's the most common, right? Over half of the injections that lead to blindness are from nasal filler, and we'll get to that in a little bit. And then almost 80% of these were in Asia, which we kind of knew that already, right? I mean, when you talk about the Asian aesthetic, there's a lot of focus on the central face as far as creating volume and shape, but certainly points to how that is a high-risk area. And the other thing I thought was great, and I appreciate you bringing this out, is we always hear, well, filler injection could cause CNS involvement or stroke. But you put statistics to it. You showed that 18% had CNS involvement. So that's almost 20%, meaning almost 1 in 5 of the cases, there was some type of pathology that bypassed the central inner artery and went into the internal carotid system. So that's a real phenomenon. And then the last thing is retrobulbar injection. We'll get that in a little bit, but I think there's some nice things you can talk about regarding that. So my first question to you is about nasal filler injection. You know, you showed in the study it's the most common location of filler-induced blindness from injection. Can you tell me, do you do nasal injection in your practice? And if so, what would you recommend to the injector as they incorporate that in their practice as far as safety, protocols, and technique?
I do it. I do it with the most enormous care. I discuss the risks with the patient because they only want to have an anatomic change, and they certainly don't want to consider getting any CNS or visual dysfunction, and they don't know about it. So you have to go through it very carefully, and if they're scared off, then you shouldn't do it, of course. Once they say, no, I really want to have it done, then I think you have to look at how to do it and what to do it with. I think hyaluronic acid is the best filler to do it with. I learned from the great Waffles Wu in Singapore that a 31 gauge needle and a tiny syringe, so that you're not trying to push a huge column with major force. You're using very delicate force, very gentle, tiny droplets, rather like you were injecting liquid silicone in a micro droplet technique. But the most important thing is to take the tip of that needle away from anywhere near the blood vessels by simply pinching up the bridge of the nose with your non-dominant hand. And just go But I think that there have been techniques suggesting using a larger needle and driving it straight down. I think that's probably going to end up in some kind of difficulty. I think lifting, you see, really where you're injecting for is doing micro droplets that are deep dermal or immediately subdermal.
Right.
And that has been so far so good. I touch wood, but that's the best. I think that there's so much variation in anatomy. There's really nowhere in the face that is completely safe.
No, I would agree. I think you're absolutely right. And the thing is, this is becoming kind of a social media phenomenon, this liquid rhinoplasty. And I think it's important for injectors to understand the anatomy, the intimacy of it, and of course, obviously the potential for complications. Which brings me to my second question. You know, there's this old teaching in cosmetic medicine and surgery, you shouldn't do the procedures you can't treat the complications for. But yet every day, all of us inject filler knowing that we could potentially have a dreaded complication like this, and we can't necessarily treat the complication. So based on your expertise and your study literature, if you were to have a blindness from filler injection in your office today, what is your personal protocol? How would you approach it?
Well, I think you have to be scared that it's going to happen to you every single day. So what you have to do is prepare.
Yeah.
And you need to make sure you understand the vascular anatomy yourself and the variations in vascular anatomy. You need to make sure that you've trained your team and what to do if there is this emergency. And you need to realize that it's not just the vision, that there's the 20% chance there could be CNS involvement as well. So really the important thing I'm lucky to be an ophthalmologist, but I learned so much from plastic surgeons and dermatology. I think that it's very important that if you're a cosmetic filler injector, that you have a really wonderful relationship with your local oculoplastic surgeons or retina surgeons, and they will be able to help you. But why would they leave, a crazy busy office of their own if you haven't taken the trouble to respect them and to tell them what this is all about and how they're be extraordinarily rare that this would be a case where you would contact them, but this is what it would be about. We couldn't just send a patient to the emergency room and say, well, good luck.
Yeah.
I mean, you have to deal with it yourself right then and there. So then you come down into the panicky situation where the patient is probably vomiting and in pain, and everybody's feeling really quite stirred by this awful tragedy. You have to take their visual acuity. Now, if you don't have a near Snellen card, you can take a page out of a magazine and test one eye at a time to see if what they can read. The other clue is to look at the pupils, because if they are truly blind, there is a big change so that you've got a blown pupil on the side of the vascular occlusion. And then you can use a flashlight or an ophthalmoscope and go back and forth with the light, the swinging flashlight test. And so when you get the flashlight onto the normal side, the pupil constricts. And when you take it back to the side that's occluded, the pupil dilates. So you need to get your staff member to take a photograph of the face, including with the eyes open. So you've documented not only the pupil size, but also the motility, because often they get a third nerve palsy. So the pupil, the eye is out and down and the lid is dropped. Then you need to figure out what else you're going to do to try and restore circulation. I've been very impressed with the fact that if people get treatment right away, they have the best chance of getting better.
Right.
Recent studies show we probably don't have 90 minutes. We probably have more like 15.
Right.
And so we can't send them to anybody else. I think injecting repeatedly, as Claudia De Lorenzi has shown, in the supraorbital and supratrochlear areas close to those foramina with hyaluronidase is a really good idea. And I'm not so sure, although I have to confess it was Steve Fagan's idea and I supported it fully to inject retrobulbar. But I think that there's so much, as you point out, technical difficulty in doing that for the person who hasn't had to do this before in their lives. And if you perforate the globe, you can actually make a bicycle eye. So I think that it's probably better to stick with the area supraorbital, supratrochlear. And then you have to figure out other ways to reduce the intraocular pressure. Massage is good, targeted massage, timolol drops, intravenous mannitol, intravenous Diamox, 500 milligrams of IV Diamox. You can, if you're an ophthalmologist or you've got one close by, can use a Gracie knife and just pop it into the limbus and drain out the aqueous. So that really dramatically reduces the intraocular pressure. What you're trying to do is to get that embolus to go further away from the central vision. It is possible to get a result that is good. The longer you leave it, the more difficult it will be.
Yeah. No, that's excellent. I mean, you heard it right here from the expert. A couple things I want to point out. As you mentioned, informed consent before you do anything with the patient. If it does happen, get that vision exam. I think you brought up a good point, retrobulbar. You know, as you know, the rabbit model to describe that, the exposure of the central retinal was more as far as not having dura around it. Whereas in the human, it's really 5 millimeters, and so there's not a whole lot of penetration we might even get. Plus, the volume of hyaluronidase you have to inject based on recommendations can inherently increase intraocular pressure pretty significantly on its own, let alone what's happening with it. So I think it's great what you mentioned, the concept of decreasing the pressure, the eye drops, the ocular massage, the IV mannitol, Diamox. I mean, those are all helpful. And as you can see, we're still figuring it out. We're still trying to find the right algorithm. You hear a lot of discussion about cannulas and needles relative to this topic. And you guys address it a little bit in your discussion of the paper. And I wanted to bring it up because some of us are married to cannulas, some of us are married to needles, some of us do both. There's been studies out there showing that there's equal penetration force of a 27 gauge cannula versus a needle. It's a little foggy when you get to larger bore, but talk to me about your personal preference, cannula and needle, why not, and just kind of shed some light on that for us.
I've tried cannulas, and I have lots of friends who are cannula Nazis, and I'm actually probably more a needle Nazi, but I'm a different kind of needle Nazi, because what I really like to do is to do antegrade injection. So I just get the needle. I find it much easier to get the needle under the skin than I do the cannula, and then I start injecting right away, so that the fluid is coming, the filler fluid is coming out of the tip of the needle, and that is what is pushing its way into the tissues rather than the sharpness of the needle. And I think because we know we can get into a vessel more easily with a tiny gauge with these hyaluronic acid fillers, it's really good to use something bigger like a 25 gauge. But I think with either, since you can get into a vessel with a cannula or a needle, the antegrade technique rather than retrograde is so much easier and so much better. They just don't bruise the same way.
Interesting. Well, that's a nice tip. Thank you for sharing. I know some people are also on that antegrade versus retrograde, but I've seen other injectors inject antegrade and they really like it. So I appreciate that point. Now, the real question is, where do we go from here on research? You know, we obviously want to fix this. We want to figure out a way to treat this complication. Where do you see future directions to try and explore this concept of vision loss from filler injection? Where do we go next?
Well, we've got a pretty good substance right now, the hyaluronidase, and it's not that expensive, and it does wear out. You have to replace it about every 3 months, and you have to make sure you have enough of it in case this happened. And it would be enough, we would have enough to help colleagues as well if they didn't have it in their office, obviously. Urokinase is another clot buster. But it's really expensive. You have to use something like 4,400 units as a loading dose, and then you have to keep on putting in 4,400 units, and the cost is around between $15,000 and $50,000, which is fine if you restore their sight. But I don't have any urokinase in my fridge. I think that we need to also look at struggling to understand why some people get this and other people don't. And it could just be that there's a difference in their vascular anatomy. There was a recent MRI study done of the cerebral circulation in a group of people who had atherosclerotic symptoms. And it was something like 20 out of 1,600 had an anomalous circulation where there's the middle meningeal artery, which is an external carotid derived vessel, then it was the only supply to the ophthalmic. So that's one way. So maybe someone has really unusual, aberrant vascular anatomy, which you don't know about, but you could find this out with an MRI.
Right.
So that's a thought too, that you could actually pre-plan all your filler patients with an MRI. I think that there are other vascular anomalies like the angular to the infraorbital. There's really weird anomalies that you can't tell just looking at people through their normal skin. I think the ultrasound probe idea to try and plot out for each individual, map it out where their vessels are in the regions you're going to inject is a good idea. I had almost signed up to go to a course on this, and then COVID hit. So I hope that people are going to restore that educational opportunity for us all. But essentially, I think we have to keep the conversation going because we don't have the answers yet.
Yeah, no, I 100% agree with you. And I do think you're right. I mean, injection's a blind stick. Ultrasound, I use ultrasound for mapping, and I've been doing some research on it myself, as well as some of my colleagues. And I would agree, it's our first chance at real-time imaging, right? That's resourceful right there. Similar to when we ultrasound the neck when we're looking for a place to put a central line, for example. So, I think ultrasound will gain in popularity both as a pre-screening and maybe even as an injection assistant tool, right, to give us a visualization there. And then you hit the nail on the head. As an anatomist, the one thing I tell people is that, unfortunately, the one cold, hard truth of anatomy is it's inherently variable, particularly the vascular anatomy.
Yeah.
So any opportunity we can do to map that out and respect its anomalous nature is key.
Mm-hmm.
Well, I think our time is up. I want to thank you so much. It's really an honor to visit with you, and thank you for sharing your insights and expertise. And we'll look forward to hopefully more stuff coming from you and your research team in the future. And for all those, we'll look forward to seeing you at the next Cosmetic Corner interview. So thank you, Dr. Carruthers. Thank you so much.
For your courtesy. Thank you.
Bye-bye.
Bye.